Hi, for our project we looked at hyperbaric oxygen therapy in those with diabetic foot ulcers. So we wanted to see if using hyperbaric oxygen therapy in addition to standard of care in those with diabetic foot ulcers led to better outcomes. We included a definition of standard care for you at the bottom of the slide. This is the Wagner ulcer classification system that we learned about in class to scale diabetic ulcers. Hyperbaric oxygen therapy has been found to be most beneficial for those with diabetic ulcers of a Wagner grade 3.
So we're going to start by breaking down the different sections of our PIGO question just to get a clearer picture. The first portion involves diabetic foot ulcers. Prevalence is anywhere between 5 and 7% of the population. They're estimated to have an ulcer of the lower extremity, which vary in severity. Risk factors include PID, which is the most common and occurs in over half of the diabetic ulcers. Pain is usually uncommon due to the diminished sensation, so oftentimes they'll be walking around and not even realize that they have a wound forming. Other complications that go along with the diabetic foot ulcers include orthopedic abnormalities, which an example of that is excessive pronation that can lead to a risk of an ulcer on the medial forefoot, as well as difficulty with wound healing, neuropathy, and they can also be susceptible to infections such as osteomyelitis. A little more about osteomyelitis. It's an inflammation and an infection of bone that's caused by bacteria. The infection can travel through the bloodstream or spread from nearby tissue. About 2 in 10,000 people can be infected with osteomyelitis. Some risk factors include diabetes, PID, a weakened immune system, joint replacements, or deep fracture or wound. Some signs and symptoms can include deep pain, muscle spasms, and fever. And the gold standard for our diagnoses is a bone biopsy. To address diabetic foot ulcers and potential osteomyelitis, we must consider using the standard care. Here is a list of the components included in the such care. First, we have debridement, which is removal of all devitalized tissue and surrounding hyperkeratotic tissue. This is also the first step in evaluating a foot ulcer. We want to make sure that we're maintaining glucose levels, so we're keeping it under the 200 milligrams, and the HbA1c is under 8.8%. This is going to hopefully ensure that the wound will in fact heal. Nutrition is also very important, so we want to increase protein, calcium, potassium, fiber, magnesium, and vitamins A, C, and E. Here is just a list of a few items that we can suggest to our patients. Antibacterials, hopefully they will help with jump-starting the wound healing process and even removing any infection that may occur. Dressings, we want to appropriate accordingly, so depending on how much exudate we have, we can use any of the ones listed here. With offloading, this is considered the gold standard for plantar heel offloading. So we might want to consider this with our foot ulcer, depending on the situation and what stage they are in their healing process. And last but not least, we want to consider education, so making sure that they have proper hygiene, they're doing skin inspections daily, they're exercising, there's proper fitting shoes, and there's regular visits to the podiatrist. Hyperbaric oxygen therapy is pretty much a compression chamber that exposes the patients to intermittent oxygen, that's 100% inhalation below sea level pressure. And it's designed to increase the supply of oxygen to poorly perfused tissues to enhance the body's natural healing process. It stimulates growth factors involving angiogenesis and other mediators of the wound healing process. Generally, it's performed daily for a minimum of 30 treatments. Each treatment goes for a total of 1 to 2 hours of 100% pure oxygen breathing time. And 2 goals for hyperbaric oxygen therapy is just cellular proliferation and angiogenesis. These are just 2 pictures of the chambers that you would put your patients in to receive the oxygen therapy at below sea level pressure. So this is just a list of indications and contraindications. Some indications to highlight would be osteomyelitis, severe anemia, necrotizing soft tissue infections, acute thermal burn injury, compromised grafts and flaps, delayed radiation injuries, arterial insufficiencies, crush injuries, compartment syndrome, air and gas embolism. As far as absolute contraindications, they include untreated pneumothorax, chemotherapy, alcoholism, medication, and antibiotics. Relative contraindications would be asthma, high fever, pregnancy, seizures, COPD, upper respiratory infection, pacemakers, epidural pain pump, and more. Etiology of diabetic foot ulcers is multifactorial, which is why HBOT is good therapy for these patients, because angiogenesis is also multifactorial. It has been shown to reduce amputation rates in patients with diabetic foot ulcers because it promotes complete healing in patients with Wagner grade 3 or higher and have undergone surgical debridement of the foot, as well as those with a Wagner grade 3 and has not shown any significant improvement after 30 or more days of treatment. It's also been shown to decrease inflammation by inhibiting prostaglandin, and it increases the amount of oxygen within poorly perfused tissues. So it combats the state of hypoxia. And in order to select patients for this type of therapy, various objective vascular eval methods have been done, such as capillary perfusion pressure, transcutaneous oximetry, and more.
The first study we took a look at is the effects of hyperbaric oxygen therapy on healing on diabetic foot ulcers. So what they did is, in order to be in this study, you had to be over 18, you had to have a foot wound present for 4 weeks despite appropriate wound care, and it had to be a Wagner's grade 3. So they took 100 total participants, 50 of them just got standard of care, the other 50 got standard of care plus HBOT therapy. So what they did for the only difference HBOT is they put them in a unit-chamber pressure room at 2 to 3 atmospheres for 90 minutes. They did this for a total of 20 to 30 days, and they alternated either 1 treatment a day or 2 treatments a day. But the conclusions were pretty significant. They had 33 of the patients that didn't receive HBOT had to get further debridement, or they had to get the leg amputated, or 0 of the patients that got the HBOT therapy needed the amputation and debridement. You can look at some of the pros, some of the cons. It was a randomized control trial, which is great. The group that actually did better had some risk factors against them, so it just shows that the results are significant overall.
Here's another study that we looked at. The purpose of the study was to see if using hyperbaric oxygen therapy in addition to the standard of care had a significant impact on healing by looking at the size of the ulcers. For procedure, all patients received standard of care for their diabetic ulcers, and all patients received their treatment as outpatient for 90 minutes a day, 5 days a week for 30 sessions total. They either received room air for the control group or oxygen for the experimental group. For their results, they found that 5 of the 8 patients that received hyperbaric oxygen therapy were healed at 6 weeks and 1 year follow-ups. For those in the control group, only 1 of 8 patients showed healing at the 6-week follow-up, and then none showed healing at the year follow-up. The pros and cons to this study were that it was double-blinded, so only the operator of the hyperbaric machine knew which treatment the patient was receiving. So neither the doctors, the patient, or the caregivers were aware of what treatment they were receiving. Also, this study looked at the population we were interested in, those with diabetic ulcers. However, it was only described as lower extremity ulcers and not foot ulcers, which we were more concerned about. In addition, the study only had 18 participants, which makes it very hard to generalize this to a bigger population of those with diabetic foot ulcers.
Here's another article that talks about the effects of hyperbaric oxygen therapy in the management of chronic diabetic foot ulcers. So in this study, they had 94 patients with diabetes. They had at least 1 full thickness wound below their ankle for at least 3 months. They had to have previously been treated at a diabetic foot clinic for at least 2 months. They also needed adequate distal perfusion, which was assessed by a vascular surgeon. So for this study, they were randomly assigned to either the hyperbaric oxygen therapy group or a placebo group. So each group got the HBO treatment for 5 days per week for 8 weeks, so a total of 40 treatment sessions, and the treatment period was about 85 minutes long. And all these treatments were given as an adjunct to just the regular treatment for a diabetic foot ulcer. And what they found was they had complete healing occurred in 61% in the HBOT group and only 27% in the placebo group. And they also had a low frequency of adverse effects to the hyperbaric oxygen therapy. So, according to this study, this hyperbaric oxygen therapy is a good adjunct for helping to heal chronic foot ulcers. So, based off of the findings of all these studies and what we found, our clinical bottom line is that in patients with diabetic foot ulcers of a Wagner grade 3 or more, and they have not responded to standard of care for 30 days, hyperbaric oxygen therapy leads to increased healing rate and increased healing completion. There is also some evidence that shows that it may decrease the need for debridement and amputation in those with diabetic ulcers. For implications for us as physical therapists, we want to make sure we identify the patient's appropriateness for the hyperbaric oxygen therapy. So like what a lot of the articles said, if they have chronic diabetic foot ulcers that have failed regular treatment, identifying the contraindications for the hyperbaric oxygen therapy, education on the therapy, its potential benefits, side effects, its role in the healing process, and just patient education on diabetes in general, about wound care and dressings, maintaining good weight, good nutrition, make sure their glucose levels are in check, proper shoe wear, skin checks, things like that. Acutely, we want to work on like gait training, possibly with assisted device depending on their footwear, if they're wearing a total contact cast, and their weight bearing status. And what we can do is ankle pumps, long arm quads, seated marches, and TheraBand exercises to help improve blood flow and maintain motion. For post-ulcer healing, we want to just continue improve lower extremity range of motion and strength through stretches and regular therapeutic exercise to really help improve the overall biomechanics during gait. For the clinical practice guideline recommendations for the use of hyperbaric oxygen therapy, patients diagnosed with Wagner grade 2 or lower should not be using this. Although patients diagnosed Wagner grade 3 and above that have not shown significant improvement after 30 days of treatment, it is suggested to add this in conjunction with standard of care to help reduce the risk of major amputation and incomplete healing. It's also evidence to use this with Wagner grade 3 or higher who have just had surgical debridement of an infected foot, and it is suggested to add this therapy post-op along with standard of care to help reduce the risk of major amputation and incomplete healing as well.
So we developed a case study. Her name is Karen. On the slide we see a lot of the details, so I'm just going to highlight the important aspects. So Karen is 57 years old. She had a diabetic foot ulcer on the plantar aspect of her right foot. She has A1C levels that are 9.7, so they're already elevated. When you first observe the wound, it's about 70% slop, 30% granulation tissue, and you notice that the calcaneus is visible. So her past medical history shows she has type 2 diabetes, hypertension, COPD, and has had a DVT in the past. When taking a look at the medications, you can see she's on Coumadin and insulin, so we really want to make sure that we minimize the risk of excessive bleeding. Social habits, she smokes, but she's down to about half a cigarette a day, half a pack a day, and living environments with her husband, and we'll highlight these features in the next slide. So as you can see, we took her highlighted information and implemented it into the IFC. Type 2 diabetes, has a foot ulcer on the right foot, and eventually we're going to find out she has osteomyelitis. So what this is causing is decreased weight bearing through the right lower extremity, impaired balance, decreased sensation, bilateral due to the diabetes. Because of this, she's having difficulty going up and down the stairs, unable to ambulate over uneven terrain far distances, and it's really impacting her ability to do things like walk her dog, to plant things in her garden. Environmentally, she's got a full flight of stairs to the bedroom. It's difficult due to the steps, but she has a supportive husband. Personal factors, we're looking at that half pack of cigarettes a day. That's going to be a negative feature, but she is highly motivated to get better. So when seeing Karen on your first day, we really want to make sure we do a great examination. So it's the basic things you're going to do with most patients. You're going to do observations, you're going to look at the edema, you're going to get measurements, both of the wound and the surrounding area, sensation testing, monofilament, vascular status with pulses, things of that nature. Now, really what we want to start with is the standard of care. So it's going to be patient education, things like skin checks, smoking reduction, A1C levels, getting them lower than the 9.7 that she's at. Because it's a diabetic foot ulcer, we really want to focus on offloading the heel. This is going to be the most important factor for her to get better and decrease the size of that wound. We decided to do a pulse-about suction because she's on the Coumadin. We are worried about increased bleeding. This will try to minimize that, and it's good for the slough that's in the area. After that, because the bone is still visible, it's a good idea to get a biopsy, which revealed that she had osteomyelitis. Things like dressing, antibiotics, moisturizer, etc. So those are going to depend on what we're actually seeing. We'll leave that up to you guys. Really, where PTs come in additionally is continuing with the therapeutic exercise. It's really important to keep the blood flow down to that area, so doing some active movements. Therapeutic activities, she might be in the bed a lot, so you want to teach weight shifting, postural corrections, make sure there's no increased pressure on that heel. Specifically with transfers and gait training, we want to think about offloading it, so you want to teach her some compensatory strategies to make sure we're not putting any weight through the heel, maybe either doing toe touch or considering giving her an AD to completely offload it. When we're progressing it, you can do it through intensity, duration, frequency, decreasing assistance, or making the ambulation improve. So, as you notice, we haven't included the HBOT therapy yet. Typically, you're going to use this after wound closure does not heal normally. So here, Karen didn't heal after 4 weeks. This is where we're going to implement it. We took the normal value, so she's about in there for an hour and a half. Total treatment time with the oxygen at an hour, from 2 to 2.4 atmospheres. So you're going to put the patient in this, anywhere from 2-3 weeks in that general area, but you want to make sure you're continuing your standard of care, so offloading, debridement, everything, things of that nature. As the patient gets better and this wound gets smaller, you want to increase the weight-bearing status, remove the AD when necessary, stair training, continue with all those active exercises, but maybe increase the frequency, duration, things of that nature. So post-ulcer, we want to make sure she's getting back to the activities that she likes, like walking and gardening. Stretching and strengthening is still going to be key, and you want to make sure the patient education factor continues all the way through.